So our patient was a 76-year-old male diabetic who had undergone CABG 10 years back. He now again presented with new onset dyspnea on exertion and angina on exertion for the preceding 2 months. So he had undergone CABG with arterial graft to LAD and venous grafts to diagonal and PDA. So at presentation, his clinical examination was unremarkable. ECG showed STT changes in the inferior leads and the lateral leads. Echo showed an ejection fraction of 50% with infravol hypokinesia. So this is the angiogram, coronary angiogram of the native vessels showing calcified triple vessel disease. And this is the RCA. And we performed, and the graft angiogram showed patent lima to LAD and patent SVG to D2. However, the venous graft to PDA was completely occluded. So because of the symptomatic presentation, we decided to revascularize his calcified RCA. So as you can see, the RCA is diffusely calcified and there is a ostial involvement too. So we discussed with the family and went ahead with the revascularization. We knew we had to use some kind of calcium modification, so we knew we had to use a rota ablation for this case. And there was ostial involvement also. So we wanted a good support for the case. So we took 7 French AL1 and we used transfemoral access for this. And we had put up TPI for in case of bradycardia. So we started the rota ablation with a 1.5 mm burr, starting from the ostium to the mid of the RCA. And then we repositioned the rota burr and give another run from proximal to the distal of the RCA. We post-dilated this. We dilated with a 3 mm NC balloon. So this was the diffusely calcified RCA. This was the first initial runs of the rota, and then the final run till the distal RCA. Okay. So this is how the angiogram looks. So this is rather a long video, so I'll summarize this. So this was the summary of the Ivus run before stenting, which showed there's the diffuse calcification. There's a calcium ring from 180 degree to up to 360 degree at different positions. And the distal and the vessel diameter at the mid RCA was 3.6 mm, and the vessel diameter at the ostia was 4.8 mm. After rota ablation, and looking at the Ivus images, we knew we needed further plaque modification, so we used a cutting balloon of 3 mm. And after cutting balloon dilatation, we saw that there was adequate dilatation of the NC balloon after that. So we knew that the expansion was adequate and did not need any further calcium modification. So we put 3 overlapping stents distal to ostial RCA. And then after stenting, we post-dilated it further with 3.5 mm, 4 mm, and 4.5 mm NC from the distal end to the ostial end. So this is the final angiogram of the RCA, and this is again the Ivus run post-stenting. So we can see that the stent is well opposed and well expanded. And we can see that at the distal RCA, the MLA was 6.8 mm square, and at the ostia, it was 9.7 mm square. So after the angioplasty, we saw that there was a PDA lesion, and it was ambiguous in nature, so we didn't know whether we need to tackle it or not. So we performed FFR for this lesion, and it was non-ischemic. It was 0.86. So we left the lesion alone. And at 6 months of follow-up, the patient is doing quite well. So the take-home message is that when we are planning such cases, we need to have a good catheter support. So we took 7 French AL1 instead of a routine Churchian site. And I was demonstrated a diffuse up to 360 degree arc of calcium. We used rota ablation, and after rota ablation, when we saw in the imaging, we knew we needed additional calcium modification, so we used a cutting balloon for this. And post-stenting, I was demonstrated a well-opposed and well-expanded stent. And after angioplasty, we had a ambiguous PDA lesion, for which we did FFR, which was non-ischemic. So we could easily leave it. So finally, we had optimal anatomical and functional result for the PCI. Thank you.